Okay, thank you very much for the opportunity to speak today. I'm really indebted to Dr. Baker actually for so much of this talk. And so I'll be talking today about 3D image guidance for intraoperative ablation. I have no financial disclosures to report, but when I perform microwave ablation, it's with 2D ultrasound, not 3D, and it's usually performed open. So definitely had to rely on Dr. Baker here for a little guidance. So with image-guided ablation, we've got B-mode ultrasound, contrast-enhanced ultrasound. Dr. Hagopian will hopefully be touching on a lot of ultrasound techniques in her talk. And then we also have image fusion platforms. These are usually not available, at least in my OR, because they require a CT scan. So where you put markers on the outside of a patient's body, you perform a CT. It's usually performed in IR. And then there's augmented reality. We have overlay of 3D visualization of target anatomy in real time. And you need a display for this, whether you're wearing goggles, over your face, your glasses, or a screen that can demonstrate the 3D anatomy. So why even perform 3D image guidance for liver ablation? So I'll show you some limited data that demonstrate that it can improve identification of liver lesions and accuracy of ablation antenna placement while you're performing ablation. It improves complete ablation of the lesion of interest, so you can hopefully reduce your local recurrence rates. Just as important as it is to target and completely ablate a lesion, you want to avoid critical biliary and vascular structures, and 3D ablation may help with this. Additionally, I'll show you some data on faster targeting and decreased intraoperator variability. So in terms of commercial platforms, it's really the Imprint by Medtronic, which is a available platform for 3D imaging. And it pairs 3D electromagnetic spatial antenna tracking, so on the tip of the actual antenna, with real-time ultrasound, and you can visualize the virtual ablation zone for planning of your ablation. So you can see here, and I'll show you some additional images, the actual antenna that's going in, that's being tracked in real time. You can see your lesion of interest in 3D visualization on your screen, and then at least for this system, it does also allow for simulation of your ablation target. So again, thanks to Dr. Baker, who was a co-author on this paper. And what they did in this paper was they had a lap ultrasound trainer, and they compared typical laparoscopic ultrasound to 3D image guidance ultrasound. And they looked at novices, senior residents, and experts, so HPB surgeons, and they were just looking at any differences between usual lap ultrasound and 3D guidance. And you can see here what I highlighted was that the number of hits versus misses, it was improved with the 3D guidance. So this is, doesn't matter how many times it took, but the fact that you actually hit the lesion. The first time hit rate was substantially higher if you use 3D guidance. And lastly, the time, so percent hit in less than 30 seconds. So actually targeting your lesion in a fast manner, all increased with the 3D guidance in this study. So just focusing on the HPB surgeons, we can sort of ignore the non-surgeons and the senior residents who were involved in this study. You can see here that the hit target on the first attempt was only 20% using lap ultrasound, and that overall of the 40 lesions that they had in their trainer, they hit 90% of them. And the mean time to the hit target was 47 seconds. It's a lot faster than me. I don't know about everybody else out in the audience, but these are also people who do probably more lap ablation than anyone else in the country. And then the average attempts to hit the target, it took them a median of 3 times. With 3D guidance, though, average attempts to hit the target, it was 1. Successful target hit, they were 40 for 40, and it took them a median of 5 seconds, a mean of 8 seconds. So that's really, really fast targeting. This is from their paper. This is what it looks like. And you can see the setup, so you have to have your eyes on lots of screens. This was their 3D trainer here. or their trainer that they had their laparoscope and their ultrasound probe in. But there was the ablation platform, the imaging screen here, and then the lap screen. This has now been just the ablation platform and the 3D imaging seem to be on one screen now with the newest update. But this is from their publication. So you do have to have your eyes lots of places. And again, taken from their publication, what this looks like. All right, what about clinical outcomes? So this is a single center prospective study that was performed right here in Cleveland at the Cleveland Clinic. It included 100 patients who had multiple tumors, so 301 ablations overall were performed. The median follow-up of patients was 16 months. They reported a local recurrence rate overall of 6.6%, colorectal liver metastases, which we'll go into in a minute, local recurrence rate was 12%. So these were the reasons why they offered microwave ablation to these patients, typical reasons to offer ablation over resection. And these are the results. So in real-time use, again, 100 patients, 301 lesions overall. Most patients had colorectal cancer. Most lesions were neuroendocrine tumors, so just more tumors per patient. Number of lesions, the median was 2. Size of lesions, these were relatively small, 1.5 centimeters. And the local recurrence rate, 6.6%. The time to recurrence locally was 7 months. And then in the colorectal group, it was a 12% local recurrence rate. For the local recurrences, the average tumor size was a little bit larger. It was 2.4 centimeters. And most recurrences were within a close margin, close proximity to a major vessel, which for this study, they categorized as within 4 millimeters. And most recurrences were in peripheral rather than centrally located tumors. When they performed multivariate analysis for risk factors for local recurrence, it was colorectal liver mets, larger tumor size, and a smaller ablation margin, less than 5 millimeters, that came out. But this is how this demonstrated, at least in clinical practice. Let me just see if this will work. Do we have an internet connection? We may. Hopefully it does work. Okay. The reason I'm showing this is the first time I'm ever using this system. I'm not an expert when it comes to 3D guided ultrasound ablation, but this is the first time I'm using this at HPBA from 2 weeks ago. And you can see, while I may not hit this target in 8 seconds, it doesn't take me really that long. So it just demonstrates the sort of ease of use. Granted, it was a pretty easy to find lesion. But this is the actual, what this now looks like. This is integrated with the ablation as well as the image guidance in once. And you can see the red circle is where the actual ablation zone was going to be. So it seems like it would be quite useful in clinical use. All right, enough of that. To conclude, 3D imaging with the limited data available does seem to improve efficiency in locating and targeting liver lesions. And in real-time clinical use, local recurrences as low as 6%. And with larger tumors, colorectal liver mets, and narrow ablation margins, certainly a risk factor for local recurrence. Thanks very much for the opportunity. Happy to take questions.